welcome back after the coffee break, and we're now on to our last session, and this is definitely a case of last but not least. It's a really great honor to have Giacomo De Luca from Milan coming all the way to talk to us about his amazing work in systemic sclerosis. I read a lot of your papers, and I'm really looking forward to this talk and getting some insights, and hopefully we have a bit of time at the end for discussion. Thank you very much for coming.
Thank you, and thank you for the kind invitation. I'm very happy to be here in Edinburgh. I will talk about a specific topic. I see that most of you are cardiologists. I'm a rheumatologist. I work in Milan. My primary choice was cardiologist when I was at university, so that's the reason why I finally decided to be interested in systemic sclerosis, primary heart involvement. And we will see how to diagnose and how to treat systemic sclerosis heart involvement. I have no conflict of interest. Systemic sclerosis is a rare chronic immune-mediated condition characterized by skin sclerosis, which is the major clinical manifestation, and that can affect several organs, including the heart. The heart can be indirectly affected as a consequence of pulmonary disease, including interstitial lung disease or pulmonary arterial hypertension, or as a consequence of renal disease, or it could be even directly affected by the disease itself. In this case, we refer to direct or primary cardiac involvement, which is frequent in systemic sclerosis, even though often underdiagnosed. And this is mainly due to the fact that it could be completely asymptomatic, especially at early stages. So it's quite challenging to diagnose. One symptomatic cardiac involvement could present with different clinical manifestations, including arrhythmias and eventually sudden cardiac death, myocarditis, pericarditis, microvascular involvement, and heart failure with both systolic or diastolic dysfunction. The prevalence is really difficult to define because it's still unclear. It ranges from 7 to 40% because it primarily depends on the different sensitivity of diagnostic tools that we can use, and the difficulties in distinguish what is primary heart involvement and what is secondary heart involvement, so related to lung disease. If we look at autopsy study, almost all patients with systemic sclerosis have some myocardial changes. What is sure is that the prognosis is really bad. 30% of all scleroderma-related mortality is due to cardiac complication, primary or secondary, and 12% of all disease-related deaths are related to primary heart disease. So prevention is a major goal. These data were recently confirmed by recent analysis in the USTAR database, which is the bigger cohort of patients with systemic sclerosis. So our major goal as clinicians is to early detect cardiac involvement in scleroderma patient. A key for an early identification is to define cardiac involvement, which seems obvious, but is primary heart involvement in scleroderma has been only recently defined, thanks to a work with the European Society of Cardiology, Heart Failure Association, and the World Scleroderma Foundation. And nowadays, primary heart involvement is defined as the presence of cardiac abnormalities that are predominantly attributable to systemic sclerosis rather than other causes or complication of the disease, including the lung and kidney manifestations. The definition states that cardiac involvement may be subclinical, so it must be actively investigated and confirmed by diagnostic investigation. And the pathogenesis of cardiac involvement comprises one or more of inflammation, fibrosis, and vasculopathy. Again, this could seems obvious to our rheumatologists nowadays, but when I start studying heart involvement in scleroderma, the notion was that myocardial fibrosis, which is the pathogenic hallmark of scleroderma heart disease, was mainly related to ischemia and reperfusion damage, so to a vascular damage. Nobody looks at the importance of myocardial inflammation in the occurrence of myocardial fibrosis. So nowadays we know that myocardial fibrosis, as you can see in this picture, this is a Masson trichrome staining which colors in blue all the collagen. So all the blue is fibrosis. Comes together with myocardial infiltration by inflammatory cells, mainly monocytes and T cells, and together with perivascular inflammation and clear vascular involvement, as you can see here or even here. So the three major pathogenic events of the disease, which is characterized by vasculopathy, inflammation, and fibrosis, could be concomitantly detected in the heart of the same patient, as in this case. These are three images of the same endomyocardial biopsy sample of a scleroderma patient with myocarditis. This was the first, this is the work of my thesis. I'm really happy to present here because when we tried to say that myocardial inflammation could be an important pathogenic event in scleroderma, still nobody trusted. This is the first in vivo demonstration that patients with systemic sclerosis could have myocarditis. In this paper, we diagnosed in 7 cases with endomyocardial biopsy active or subacute myocarditis. And the fact was that infiltration of the myocardium by inflammatory cells was associated with different degrees of interstitial or perivascular fibrosis and with signs at endomyocardial biopsy level of vascular activation. So again, the 3 major pathogenic events of the disease are there: vasculopathy, inflammation, and fibrosis. This is not surprising because in 1976, these authors said exactly the same. Looking at the myocardial lesions of progressive systemic sclerosis, they found the presence of contraction band necrosis, which are associated with ischemia reperfusion damage, so vascular damage, inflammation, and focal fibrosis again. This is another nice study in 25 scleroderma patients with clinical suspicion of primary heart involvement who underwent endomyocardial biopsy. And the author found in all of them some signs of myocardial inflammation, together with fibrosis. Higher inflammation was associated with higher percentage of fibrosis and with signs of vascular damage. So again, the 3 major pathogenic mechanisms of the disease comes together. And both the degree of inflammation at myocardial levels as well as the degree of fibrosis at myocardial levels correlated with the prognosis of these patients. So this is an information that endomyocardial biopsy, at least in scleroderma population, could provide. Scleroderma myocarditis are completely different from all other myocarditis. If we look at the myocardium of this patient, this is a paper we published a few years ago comparing the 12 scleroderma myocarditis patient with other autoimmune myocarditis, including patients with lupus, myositis, or antisynthetase syndrome, which is the A virus negative myocarditis group, the autoimmune group, and isolated virus negative myocarditis, so pure myocarditis, not in the context of a systemic immune-mediated disease. We compare clinical features, CMR features, and even endomyocardial biopsy features. And what we found was that in systemic sclerosis, the percentage of myocardial fibrotic and even the fibrotic score were much higher than other kind of myocarditis. And importantly, the highest rate of fibrosis was correlated with a worse prognosis. So patient who died was all scleroderma patient. So it seems that myocardial fibrosis is associated with a bad prognosis in this patient, mainly associated with arrhythmic complication or late stage heart failure. I don't want to spend more time on this slide, but just to tell you that even if we look deeper into the myocardium of scleroderma patient, it seems that the fibrosis is completely different from what we can find in other kind of myocarditis. These are the same patient of the previous studies, patient with scleroderma myocarditis, other autoimmune myocarditis, and virus negative isolated myocarditis. This is a spatial proteomic analysis, and what we found in this study was that scleroderma patient had completely different cell population in the myocardium, mainly basically a higher amount of CD34 positive stromal cells, and this particularly newly described CD68 mast cells, which are inflammatory cells, probably with some profibrotic effects, and this could partially explain the highest rate of myocardial fibrosis in the myocardium scleroderma patient. After this background on what is scleroderma heart involvement, let's go into the focus of the presentation, try to answer together to some really clinical questions. So how to diagnose primary heart involvement in systemic sclerosis in clinical practice. This is our proposed algorithm. It's really challenging to diagnose systemic sclerosis, primary heart disease. We should start in any case for the exclusion of other secondary causes of heart disease, including scleroderma related or not scleroderma related, and through a careful analysis of signs and symptoms of possibly associated to cardiac involvement. Even having in mind that cardiac involvement could be completely asymptomatic in scleroderma patient. If we look again at that paper, almost half of the patients with systemic sclerosis myocarditis diagnosed by endomyocardial biopsy had a subclinical onset, meaning fatigue, mild dyspnea, sometimes palpitation, or increase of troponin E or troponin T or proBNP, but nothing more than this. Chest pain is really rare, as well as signs of congestive heart failure are not frequently detected. Cardiac biomarkers could help to diagnose scleroderma heart involvement in this scenario because they are accessible, easy reproducible, cost-effective, but they are not specific for systemic sclerosis, neither for the underlying pathogenic mechanism. Their prognostic role is still undefined. And more importantly, if we look at the three major papers assessing scleroderma heart involvement with endomyocardial biopsy, so these are all patients with biopsy-proven myocarditis, the percentage of patients with increased troponin T or NT-proBNP vary a lot from 33 to 75%. So they don't really help us really much. They are useful as screening tool in the early diagnostic phases. Similarly, echocardiography, which is our routinely performed screening tool in all scleroderma patients, we perform at least every year in all patients with systemic sclerosis. It's low cost, non-invasive, etc., but is not so performing in systemic sclerosis because at least if we do not use novel techniques such as the strain analysis, there is a lower chance to detect any changes, any myocardial changes possibly associated to the disease. In fact, for example, reduction of left ventricular ejection fraction, which is quite easy to detect through echocardiography, is not so typically found in patients with systemic sclerosis. According to the USTAR database, only 5% of scleroderma patients finally have a reduced left ventricular ejection fraction. So depressed ejection fraction is not a typical manifestation of scleroderma primary heart involvement, neither of scleroderma myocarditis. More importantly, we look at diastolic dysfunction, which could be detected even at early stages and can eventually lead to diastolic heart failure and heart failure with preserved ejection fraction, which is more typically found in patients with systemic sclerosis. And is associated with a bad prognosis. Several studies confirm that diastolic dysfunction represents a bad prognostic factor in patients with systemic sclerosis. The problem is that even if it's frequent in systemic sclerosis, diastolic dysfunction could be associated with other features like obesity, coronary artery disease, lung involvement related to the disease, older age, etc. So it's purely impossible to define if that diastolic dysfunction is related to the systemic sclerosis or is a non-scleroderma or anyway, non-primary heart scleroderma related manifestation. Then we can use in this diagnostic algorithm 24-hour EKG Holter analysis because the arrhythmic burden is one of our clinical major issues in systemic sclerosis. Looking at Holter, we can find some arrhythmias, ventricular arrhythmias, but even quite frequent like presence of ventricular ectopic beats that in the context of a patient with systemic sclerosis had a great clinical impact. If we look at the morphology of ventricular ectopic beats, we can have at least an idea on what's going on in that myocardium. This recent study suggests, it's a single study anyway, but the suggestion is that irregular polymorphic ventricular ectopic beats could be associated with the presence of active myocardial inflammation, so active myocarditis, while the presence of regular monomorphic VBS could be associated with myocardial fibrosis, so inactive or healed myocarditis. And even if we look at the numbers of VBS, they have been associated with the prognosis of this patient. A patient with a high number of VBS in this study were the patient who finally died for sudden cardiac death or needed an ECD insertion due to life-threatening arrhythmias. This is a study which takes 2017, and again, this is not surprising, even if the studies from my group, because in 1988, cost is exactly the same, with the same number of higher VBS was associated with a 6-fold increase of mortality for sudden cardiac death in patients with systemic sclerosis, especially in those with a concomitant skeletal myositis, suggesting the presence of this high-risk association, skeletal myositis and myocarditis with arrhythmic burden. Finally, this was one of the major topics of the day. We need, of course, CMR to diagnose and to characterize heart involvement in systemic sclerosis. Historically, we relied on the oldest Lake-Lewis criteria, so the early gadolinium enhancement, which is associated with increased vasopermeability, hyperemia, the 2 images associated with tissue edema and inflammatory infiltration, and LG associated with myocardial fibrosis or even necrosis. But the performance of Lake-Lewis criteria in the context of systemic sclerosis, as in other immune-mediated disease, is really low because especially at early stages, myocardial inflammation, for example, could be patchy or subtle, so it's really difficult to have T2 positive STIR images. And the concomitant presence of skeletal myositis further lowered the performance of this criteria. Mapping techniques may for sure overcome this limitation by including T1 mapping, T2 mapping, which is more specific for myocardial edema, extracellular volume, which is specific for interstitial fibrosis, while T1 mapping, as Maya said this morning, it's in between. I mean, it looks a little bit to myocardial fibrosis and even to myocardial inflammation. We are able to improve the diagnostic sensitivity of CMR in scleroderma myocarditis. This is again another study from our group evaluating the performance of the old and the new Lake-Lewis criteria in confirming the diagnosis of myocarditis in patients with an endomyocardial biopsy proven myocarditis. And by using mapping, especially thanks to the addition of T2 mapping, the sensitivity improved from 53 to almost 90%. This is just representative images of a 66-year-old female patient with scleroderma, clinically manifested with dyspnea and palpitation, with a CMR showing a normal T2 ratio, but T2 mapping, which was diffusely altered. But look at the numbers, was really, these are the numbers that we see usually in scleroderma. It's 54, 56, 55 milliseconds, but suggestive for diffuse myocardial edema. This is even true in other inflammatory immune-mediated condition, like, for example, antisynthetase syndromes. Again, the inclusion of mapping techniques could improve the sensitivity of CMR to diagnose myocardial inflammation. And as you know, cardiac involvement is even common in patients with antisynthetase syndrome or other inflammatory myopathies. In this study, we evaluated in our cohort of patients with antisynthetase syndrome, those with myocarditis clinically defined, and we found some red flags possible associated to the presence of active myocardial inflammation at CMR. And look at, are almost the same, so high inflammation and high levels of cardiac biomarkers. So this may act as red flags in this clinical condition. For this reason, mapping is now widely used in clinical where available, and is even suggested by the ESC guidelines to detect active myocardial inflammation. I just would like to show some CMR images from different conditions, just to focus the attention on how different is systemic sclerosis with respect to others. These are some figures from patients with vasculitis. This is an uncorrelated vasculitis showing a depression of systolic left ventricular ejection fraction of 38%, which is really rare to see in systemic sclerosis patient with a diffuse hypokinesia. And we can see T2 STIR images with positive for myocardial edema, which is nearly impossible to see in patients with systemic sclerosis, or at least really rare to see in patients with systemic sclerosis. And even LG with some subendocardial distribution, which is not so common in systemic sclerosis when LG is mainly midwall or subepicardial. This is another patient with larger vessel vasculitis, a patient with giant cell arteritis. Again, This patient had a reduction in left ventricular systolic function and some focal areas of subepicardial edema in T2 STEER images. Here you can see in the same area of myocardial edema a sequence of subepicardial LG and mesocardial LG. If we look at scleroderma patient, back again to the previous study comparing scleroderma myocarditis to other autoimmune myocarditis and to pure isolated myocarditis, look at the frequency of STEER edema in scleroderma patient. Only 1 out of 12 patients had, while it is not so uncommon in other conditions. So this is the reason why, especially in systemic sclerosis, we finally need mapping techniques to detect myocardial inflammation. CMR in systemic sclerosis is also important as a prognostic tool because there are some studies supporting the role of CMR to predict ventricular arrhythmias. These are data coming from a multi-center European study, which is called Sanctus trial, showing that the burden of LG combined with the T2 ratio are able to predict the occurrence of future ventricular arrhythmias at 24-hour EKG alter. And it's not only a matter of tissue, but even looking at volumes and function, we could have some information about prognosis of scleroderma patient. This is an elegant UK study showing that there are different phenotypes in scleroderma in systemic sclerosis patient, and 3 of them, the one with normal function, large cavity, biventricular failure, and even worse, the right ventricular failure, are associated with a worse prognosis. These data were recently confirmed in a collaborative Italian multi-center study, so showing exactly the same survival course. So the UK population, the Italian population, if we look at the volumes and the function, say exactly the same things. The problem is that CMR, despite all these strengths, has a lot of limitation because it's not widely accessible. Is still limited to referral centers, and imaging interpretation needs a high expertise, especially in the context of systemic sclerosis or other immune-mediated disease. There is also a limited use in patients with device like ECD, and since arrhythmias are so frequent in systemic sclerosis, this is a clinical issue in our patient. And there is still a limited use in patients with severe arrhythmias. Furthermore, if we perform CMR in to 100 scleroderma patients, we will find something at least in 50, 70, 60 of them. But we should be aware that the clinical interpretation of findings in completely asymptomatic patients, so we normal EKG, normal troponin, no signs, no symptoms, no arrhythmic events, should be taken with a great caution. So we still don't know what does it mean, that finding. So we need some serial and prospective evaluation. There is a completely lack of consensus or guidelines on how to use, how to perform, when to perform, and in which patient to perform CMR. We can use some, since we discussed today, we can use even some nuclear imaging like PET, for example. FDG PET completely doesn't work in systemic sclerosis patient. We tried to use it, but with really bad results. There are instead some promising data on FAPI PET because it's more specific for myocardial fibrosis, and is even associated with the fibrotic change at myocardial level if compared with endomyocardial biopsy data. And sometimes we need invasive assessment, for example, electrophysiological study in patients with potentially life-threatening arrhythmias to identify those eligible for ECD, or even endomyocardial biopsy. I'm a fan of endomyocardial biopsy. In systemic sclerosis, we need endomyocardial biopsy sometimes to confirm myocarditis in doubtful cases, or even to rule out a viral etiology of our patients are taking immunosuppressants in most cases, so we should be aware that a viral myocarditis could be present, and treating those patients with immunosuppressant or upgrading the immunosuppressive therapy could be even dangerous. To quantify and characterize myocardial inflammation and the extent of myocardial fibrosis, which portend prognostic, which has prognostic information. And finally, because I think that this is the one way to improve our knowledge about the pathogenic mechanism of the disease. Once how can we identify a patient at higher risk of primary heart involvement? So should we perform this comprehensive diagnostic algorithm to all scleroderma patients? The answer is probably not. We have some red flags, some feature associated with a higher risk of cardiac involvement in systemic sclerosis patient. These are data coming from 2 different studies, again, one UK and one Italian. Some feature like male sex, some certain antibodies, the presence of a diffuse disease, pericarditis, myositis could be associated with a high risk of cardiac involvement. So these are briefly the feature associated with the presence and occurrence of new onset of primary heart involvement. These red flags were basically confirmed even in the study we conducted last year, trying to find some biomarkers or red flags associated with the occurrence of primary heart involvement in systemic sclerosis. And we found again that the presence of C-reactive protein elevated or high troponin T, so again, inflammation or cardiac biomarkers, together with interstitial lung disease and arrhythmias at alter, are red flags for possible presence of primary heart involvement in scleroderma. So they could guide a comprehensive diagnostic algorithm, including CMR. So these are basically the red flags that we nowadays use in clinical practice to decide which patient with systemic sclerosis perform CMR or pay more attention, focus our attention on possibility to have a cardiac involvement. But we should also consider that patients with very early disease could have cardiac involvement. This is a paper that I decided to share because, again, back to the pathogenic mechanism, it reported the possibility to have 3 different aspects of the disease: more vascular, pure inflammatory with a myocarditis in the panel B, and completely only extensive myocardial fibrosis in the panel C. So these were 3 patients with very early systemic sclerosis presented with 3 different clinical manifestations. The patient with extensive myocardial fibrosis had left-treating arrhythmias and finally had an ECD insertion. The second one had a virus-negative myocarditis treated with immunosuppressive therapy. The first one had a typical chest pain, basically related to microvascular involvement, and she was treated with calcium channel blockers and vasoactive therapy. So again, the 3 major pathogenic mechanisms of the disease, vasculopathy, inflammation, and fibrosis, could be associated with 3 different clinical manifestations. How to treat primary heart involvement in scleroderma myocarditis? If we look at our rheumatology recommendations, so the EULAR recommendation, even if heart involvement is one of the major causes of death, there are no recommendations for the heart. It's the second causes of death after the lung involvement. So this is our proposed therapeutic approach. Is what we do in clinical practice. Basically, we start from conventional cardiologic therapy, including the treatment of heart failure and diastolic dysfunction, and treatment, and even more important, prevention of ventricular arrhythmias. And treatment targeting the 3 major pathogenic events. So vasculopathy, inflammation with immunosuppressive therapy. We use conventional DMARDs, mycophenolate is the preferred one, or sometimes even biologic agent like rituximab or tocilizumab. And hopefully in the next future, we will have even some therapies to treat myocardial fibrosis. I put it down some future perspective. There is a role for vasoactive therapy, supporting the notion that even vasculopathy is important in systemic sclerosis, primary heart involvement. We know from previous studies that patients taking calcium channel blockers less frequently have reduced left ventricular ejection fraction at echocardiography. And in another study, we know that patients taking vasodilators, mainly calcium channel blockers or low-dose aspirin, had a lower incidence of some myocardial disease manifestation as QAs, cardiac blocks, or pacemaker implantation. So there is a rationale to intensify vasoactive therapy in this patient. There is for sure a rationale to treat this patient with immunosuppressive therapy, especially those with diagnosed myocarditis. In the paper on my thesis, we treated this 7 patients with steroids and immunosuppressant, which were at that time cyclophosphamide and azathioprine. Nowadays, we use more frequently mycophenolate, and we we saw a clinical improvement in all patients, together with a reduction or normalization of cardiac enzymes, and even improvement of certain CMR parameters, especially T2 edema 1%, just in one patient. In this more recent study, the authors confirm basically the same. They use CMR with mapping before and after treatment, mainly with cyclophosphamide in 18 patients with systemic sclerosis, primary heart involvement. And what we found was a reduction of T2 ratio and T2 mapping, and even a slight reduction of the burden of LG after 8 months of follow-up. This is a study that we recently published to answer the question if the immunosuppressive therapy could act specifically to treat systemic sclerosis, primary heart involvement, rather than other manifestations of the disease. We included only patients who started immunosuppressive therapy or changed the immunosuppressive therapy to specifically treat systemic sclerosis, primary heart involvement, and only patients who had the baseline and follow-up CMR with mapping. And these patients were treated with mycophenolate, most of them, sometimes with the inclusion of rituximab or tocilizumab. This was the two most frequent biological drug use. And what we found was that the percentage of patients with signs of active inflammation at CMR decreased after therapy, as well as the T2 mapping and the T1 mapping. And there was also a trend in reduction in the percentage of extracellular volume. Of course, this data were, the CMR improvement were also associated with reduction of cardiac biomarkers, NT-proBNP and troponin T, as well as of C-reactive protein. So probably inflammation was improved, as well as the number of VBS and 24-hour EKG alter. Of course, there are still a lot of things that we don't know on how to treat this patient. We don't know which is the best immunosuppressive therapy, the role of biologic and steroids, and for how long we should treat this patient with immunosuppressive therapy, as well as we don't know, this is one of the major points in my opinion, which is the prognostic meaning of these CMR changes in mapping parameters in the long-term follow-up. So are we sure that improving T2 mapping from 56 to 52 is associated with a better outcome in the long-term follow-up? We still don't know. And we should again emphasize the importance of concomitantly treating other pathogenic pathways related to the disease. There are some future perspectives to treat myocardial involvement in systemic sclerosis. Now it's the CAR-T era, so everything seems that should be treated with CAR-T therapy. There are no data to support the use of CAR-T cell therapy to treat scleroderma-related primary heart involvement. Looking at all the study using CAR-T, I found only 3 patients with some data regarding the heart. And what we can say was that cardiac biomarkers improved in one of them, and probably left ventricular ejection fraction improved in another one. But we don't have any other data, as well as we do not have a data on how to treat the inflammation-driven fibrosis. We can use the drug nintedanib, probably, but probably not. Nintedanib is an antifibrotic approved for interstitial lung disease, so for lung fibrosis, but there is only one study supporting the potential benefit of nintedanib in improving the extracellular volume at CMR in patients with systemic sclerosis. I'm personally fascinated by the use, as rheumatologist, of course, I don't know if the cardiologist agrees, but the use of SGLT2 inhibitors to treat systemic sclerosis-related primary heart involvement, because they could have in cardiac fibrosis modulation, in dampening inflammation, and even in modulating endothelial function and endothelial to mesenchymal translation, which are pathogenic events clearly important in systemic sclerosis. So to conclude, we can say that heart involvement is frequent in systemic sclerosis, even at early stages, and is associated with a poor prognosis, so should be systematically investigated in all scleroderma patients, or at least in those with potential red flags. Vascular damage, myocardial inflammation, and myocardial fibrosis are the 3 pathogenic mechanisms involved in the pathogenesis of the disease, and fibrosis in systemic sclerosis has some unique pathogenic mechanisms compared to other connective tissue disease or other immune-mediated disease. CMR with mapping is the non-invasive tool of choice to diagnose and to characterize cardiac involvement in systemic sclerosis, but should be included in a comprehensive diagnostic algorithm. And sometimes we still need invasive assessment in selected cases to elucidate pathogenic mechanisms underlying the disease. Finally, immunosuppression is an effective strategy, or at least it seems to be an effective strategy. Optimizing vasoactive therapy could also be beneficial, while the therapeutic strategy for myocardial fibrosis are still far to be defined. I conclude, and I would like to thank all of you for your attention.
Well, thank you. That was amazing, and it shows that I think you personally and your group have probably done more work in systemic sclerosis than primary heart involvement than any other, and it's brilliant to see it summarized so nicely. It shows the sheer amount of work you've done. So thank you very much for your contribution to the field. We of course are the CARDIO-IMID network. So as you probably know, this group is trying to overcome some of the current knowledge gaps by bringing in as many sites as we can from within the UK to answer some of the questions collaboratively. Is there something similar in Italy? Do you have a network of centers that contribute to some of your research?
Not so defined as in UK. I mean, it's just more a spontaneous collaboration among centers that treat scleroderma patient. There are a few centers in Italy actually looking at heart involvement in systemic sclerosis, but in general in immune-mediated disease, I have in mind 3 or 4 centers in Italy. There is a network of scleroderma unit, but it's not focused on primary heart involvement. So we don't have something like you have in UK, and this is of course not the best situation for rare diseases like this and for rare complication of rare diseases like this.
But we haven't got anything to show for yet, so we have the network.
If I can join, I will be.
Impact.
I will be happy.
And then you have a few more, but any other questions from the audience?
You very nicely showed the importance of inflammation, fibrosis. Do you think they're sequential things? Does inflammation trigger the fibrosis? Is that too simple a kind of idea, or are they, I guess, parallel processes that are going on?
This is a $1 million question in scleroderma, at least. Historically, we thought that vascular events are the early events in scleroderma, but this mainly originates from a clinical observation, the fact that systemic sclerosis initiated with a Raynaud phenomenon, which is a vascular manifestation. So the opinion is that vasculopathy, endothelial dysfunction, is the early key pathogenic event driving all others. In my opinion, it's really more than sequential. It could be that vascular events are the early key pathogenic event, but are more frequently, it's more important to think concomitantly, because there is a strict interplay between vasculopathy, inflammation, and fibrosis. There are several mechanisms, inflammatory mechanisms, foraging myocardial fibrosis. This is several data supporting the notion of inflammation-driven fibrosis. So if we dampen the myocardial inflammation, we should at least theory able to reduce the late burden of myocardial fibrosis. And even because it's the only thing we can do, targeting vasculopathy and myocardial inflammation, we are still not able to target myocardial fibrosis. So think concomitantly, I think that is better than think sequentially, at least nowadays. I don't know if Maya agrees.
Yeah, no, I agree. It's really interesting. Do you think, but even, I mean, I agree. Do you think within that there could be more than one phenotype? So within our scleroderma patients, we see those that may have relatively heightened inflammatory profile, and so other organ manifestations follow. So do you think there could be a group that do have predominant myocardial inflammation driving fibrosis, or there may be a more vascular-driven phenotype that leads to fibrosis without the inflammation? There could be more than one, because we see that heterogeneity in our patient population, right? In terms of other organ involvement, joints, skin.
I think yes. This is a correct clinical observation. We see in clinical practice that there is some patients that are more vascular, even because in systemic sclerosis we have other clues that help us to define if the patient is more vascular, more inflammatory, or more fibrotic. I think a patient with digital ulcers or severe peripheral vasculopathy are those patients which have the digital ulcers, for example, have been associated with LG and with arrhythmia burden with more fibrotic change instead of inflammatory changes at myocardial level, even if it was in the pre-mapping era. So we should confirm this data in the mapping era with T2. But I'm pretty sure that we have different profile of scleroderma patients. So I totally agree with your impression.
But patients are also individuals with comorbidities and genetic architecture. We talked about family histories, etc. So I think the disease expression is significantly impacted also then by what else in the heart is an organ at the core of many things, not just systemic sclerosis.
Yes. So that was a beautiful talk. Thank you so much. I have two questions for you. One of them is, you mentioned the biopsy. How easy is it for you? Because you had that Vidal's case, which is quite striking. Was that a specific case where the patient had any cardiac manifestations and you wanted to have a biopsy done? And then the second one is, in terms of clinical practice, are you treating all your patients with SGLT2 inhibitors, or how do you approach them in your clinic every day?
Okay, thank you for the question. So the endomyocardial biopsy depends on the expertise of the center, basically, I think. In our center, I'm lucky because I have cardiologists which are really interventional. They biopsy everyone, even me, if I pass them. So it's better to stay away from them. But to answer to your specific question, the three VEDOS patients, or very early patient, had manifestation, clinical manifestation leading to the final endomyocardial biopsy. The one with the myocardial fibrosis had dramatic ventricular arrhythmias, not responding to anything else. She only had renal phenomena and anti-RNA polymerase 3 and capillaroscopic pattern and nothing else. No myocardial, no interstitial lung disease, no ulcers, no skin thickening, nothing. So we finally decided to biopsy because I was personally fascinated by the idea that she could have an extensive myocardial fibrosis, as she finally had. The normal CMR, yes, because at the beginning, at the early stages, it was performed in another center with not so good expertise in CMR. She had 3 cardiac arrest events, so she was implanted. So we didn't have performed again CMR. This is another problem in scleroderma population. If a patient has a left atrial arrhythmias needing an ECD, we are not able to study them with the CMR. So this is the reason why we decided to go with an endomyocardial biopsy in that case. The second one, we decided to biopsy because was an anticentromere positive patient with no skin, only renal phenomena, and it's really strange to have myocarditis in patient with anticentromere positive antibodies. And again, we would like to see if the patient had myocarditis. She had dyspnea, increased troponin T. That's all. But finally, she was treated with 1 year of mycophenolate, and now she's fine. So that, I mean, it's only guided by some clinical indication. If the center is experienced with endomyocardial biopsy, it's a quite easy procedure, I think. I'm not a cardiologist, but the rate of complication in our center is less than 1%. And they perform the biopsy on the right side of the interventricular septum, despite of regardless of CMR findings. So it's a standard sites, the biopsy. Yes, I mean, but it's the expertise of the center, I think. It's not so useful. It's so common to perform biopsy in other centers, even in Italy.
There was a second question, I think, about SGLT2.
SGLT
Question.
Sorry, yeah.
Sorry.
We are starting using SGLT2 inhibitors in clinical practice. We have some preliminary data that I hope we could present in next future, but not with CMR. With CMR, we have some data, but few data. We are assessing the role of SGLT2 inhibitors in changing the strain analysis, echocardiography, and the left atrial strain, which seems to be, and the cardiologists say to me, that seems to be an important prognostic factor in cardiac remodeling. It's right, or less, yeah, it could be.
So along the same thing, you mentioned that we see subclinical involvement an awful lot. The prognostic implication isn't clear, and that's the sort of key gap. When would you advocate using immunosuppression? Because at the same time, there's anecdotal data, observational data to show that, when we give mycophenolate or normal drugs, that pre-post CMR, we're seeing changes. So where's your comfort zone at the moment for implementing, for starting immunosuppression? Is it where there's more than just asymptomatic subclinical involvement? Do you need more than that? When would you normally?
Yeah, again, this is a really difficult question to answer because it really depends. Sometimes it's easier because if we have concomitant skin involvement or lung involvement, we need immunosuppression. It's even better because we start that and it's fine. But if we don't have lung involvement or skin involvement, the only reason to start an immunosuppressive therapy is the heart. We should be really careful to decide when is the best moment and which is the best case to start immunosuppressive therapy. In my opinion, in clinical practice, if we have some clinical or biomarkers like mild dyspnea or palpitation or asymptomatic but with increased troponin T and a CMR suggestive for heart involvement, especially with the presence of T2 mapping, I would start an immunosuppressive therapy because at least what we know nowadays is that T2 mapping is suggestive for myocardial edema. In my mind, as a rheumatologist, if I have something to dampen that inflammation, I will try. I'm not sure to treat all patients, completely asymptomatic patient with no troponin, no T2, or just with some LG. I will never treat them.